BJ, a lot of the neuro exam is actually, depending on the age, is play based. In order for me to to figure out what the strength is for an 18-month-old and to figure out how the reflexes are working, I cannot just go up to them and start banging on their legs.
Hello and welcome to e-Shadowing. E-Shadowing is sponsored by me. What's going on? It is time for e-Shadowing. We have a very special guest today, Dr. Sujay Kansagra. Where are you, Sujay? Raise your hand, Sujay, if you are here. We'll bring you on. I hope you all are doing well as we're waiting for our guest to show himself. Let me know where you're watching from. Say hello. Where are you watching from, and where in this process are you? Are you first year, second year, 10th year? Hello, New York City, Marguerite. Hello. Houston, Erica. What's up? Molly's a postbac applicant. Hello, Molly. Welcome. All right, so Sujay is here. Let me promote to panelist. We'll bring Dr. Sujay Kansagra on. We'll have some fun today. Hello from Maryland. Hello, Elizabeth. Chris from the DMV. Berkeley, third year. Just finished the MCAT. Congrats on finishing the MCAT. That is amazing. Thank you for declining to be a panelist. I picked the wrong person. Let me try this one more time. Promote to panelist. Let's see if that worked. There we go. We got it. Abiba, freshman in college. Hello. Mason. Hello. Hi. How are you? Dr. Sujay Kansagra.
The good Dr. Gray, how are you?
Long time no talk, my friend.
It has been a while. I'm thinking back. I feel like we were like one of the early ones on Twitter with MedEd back in the day. So it's always nice to connect with you and catch up and,
I was just following in your footsteps.
Oh, that's not true at all. You went away, my friend.
We're going to talk today about some pediatric neurology, some sleep medicine, some Twitter meme bombing, all of that fun stuff.
Sounds great. Yeah.
Sounds good.
Let me know if you have any trouble hearing me. I can always put in my earbuds, but as long as the audio is okay, we'll keep it rolling.
Yeah, no, I think it sounds good. I don't hear any feedback on my side, so we're good.
All right.
So, pediatric neurologist.
Yes.
How do you end up being a pediatric neurologist?
Yeah, it's a somewhat of a long track, but it's a really enjoyable one. So the traditional track is 2 years of general pediatrics after medical school, so general pediatrics residency, but it's an expedited residency. So they only take you through it for 2 years, and then you switch over to the child neurology residency. And that's a 3-year program. And that combines 1 year of adult neurology training with 2 years of child neurology training.
Yeah.
And so it's 5 years total.
5 years total. Why did you want to do that? Why not be a adult neurologist? Why hang out with the kiddos?
The brain is fascinating. Lots of mysteries to the brain. And so I knew I wanted to do something brain related. And then for me, I think dealing with children, it's just a different, a different set of neurologic disorders that affect children. It tends to be more varied. And back when I was making the decision, there were a lot more things that we could do proactively to help children with neurologic disorders. Yeah. Whereas the adult side seemed a little bit more challenging when it came to being able to truly make a meaningful change and trajectory of neurologic disease. Now, a lot has changed, in the last 10, 15 years. So that's not necessarily the case on the adult side. But still on the ped side, the cases are just more varied. And then I just like dealing with children. I always felt like they were never at fault for the disorders that they were experiencing. And you just want to help kids. There's a sense of that innocence that you just want to make sure they're living their best lives and the most happy and healthy lives. And so that's where I dedicated my energy.
Yeah, it's interesting. You said, I think what a lot of people think is the quiet part, you said it out loud about they're not at fault for what's going on with them. right? And I think a lot of physicians choose pediatric subspecialties for that very specific reason of like I want to be a pediatric pulmonologist because the adults, they're smokers and whatever, and they did this to themselves. And right, obviously physicians have compassion and we're taking care of people no matter what, but it's a very common I think thing that drives people to pediatric versions of the subspecialties is like it's they couldn't help it, and so I want to be there to help.
Yeah, and that's certainly, I think that could be a driver for many people. A lot of people are just kids at heart and enjoy kind of the silliness and the little bit of immaturity that can come along with being on the pediatric side. So that's part of the reason for me too. And then, it is a little bit unfair for me to say that, adults are, many of them are not at fault, certainly. And there are lots of things that can affect adults that they have no control over.
Yeah.
But you're right. For me, I think that certainly drew me towards pediatrics. And then it's just fun. You walk down the halls of a pediatric wing of the hospital, and there are Marvel characters and all these cool characters on the walls, and it's just a vibrant place to be.
Yeah.
So
does your hospital do the Marvel characters washing the windows?
I wish they did. That would be awesome. No, I haven't seen that here. Yeah. It's
bummer. Guess
I should lobby for that because that's pretty amazing. Kids would love that.
Yeah, it's awesome when I see TikTok videos of it, which is awesome. So kids are awesome. Parents not always awesome. How, as a pediatric neurologist, do you deal with parents? How do you have any tips for students to deal with the parents? Because obviously the parents are typically going through a hard part in their life as well. Their kid potentially this new life-changing diagnosis.
Yeah, there are a couple of things. There's a lot to unpack there, but I will tell you that people oftentimes worry in pediatrics that parents are going to be either overbearing or trying to dictate care. And in almost all cases, I found parents to be just a wonderful partner in the healthcare journey for their children. The great thing about in pediatrics is that you have like an advocate in the home that's assuring that they're getting the medications and they're making to appointments where, you can't always guarantee that on the adult side. So you really have a partner in it. And parents, a lot of these parents, they've gone through a lot and they know, the challenges that are ahead for their children. And they're just really thankful to have somebody that cares about their child and is trying to help them get better. So I usually consider them as partners in the journey. And it's amazing to be able to kind of partner with them when they're going through all different parts of their lives, especially in child neurology. You have children that were born with chronic neurologic conditions that they've had to deal with their entire lives. We have children that are otherwise completely healthy and have episodic issues like epilepsy or migraine. We have children that were completely healthy and then something tragic happened and now they're dealing with a chronic neurologic condition. So being able to kind of take families and guide them through these challenging, ways of life is really quite rewarding. And it's one of the reasons why I think most pediatric neurologists don't regret the choice they made. It's really just an amazing field.
Yeah. So you also have another subspecialty within pediatric neurology of sleep medicine. Is that pediatrics as well?
For me, it is. Yeah. So I'm a glutton for punishment. So after I did my, pediatric neurology subspecialty training, I did subspecialty training in sleep medicine. And so now the majority of my practice is in dealing with sleep disorders for children. And getting to sleep medicine, which may be your next question, there are a variety of approaches, and my approach was through child neurology. But you can go through pediatric pulmonary, you can go through general pediatrics, you can go through psychiatry, you can go through internal medicine. There's a variety of ways to end up in a sleep medicine fellowship. Yeah. Almost any residency you can do prior to doing a sleep medicine fellowship.
Everyone sleeps, so you gotta figure that out.
Absolutely.
So for you as a pediatric sleep medicine specialist, so that's the majority of your practice, it sounds like.
That's right.
What is bread and butter pediatric sleep medicine?
Yeah, so surprisingly, about 80% of it is insomnia and sleep apnea, the combination of those two. And people are sometimes surprised to say, do kids have sleep apnea? And usually for young kids, it's hypertrophy tonsils and large adenoids that are obstructing their airway while they sleep. And so thankfully we have interventions for that when it comes to surgery. And then insomnia throughout the ages, all the way from infancy through adolescence and even young adulthood, we deal a lot with difficulty sleeping. And there can be a variety of reasons for it, but that occupies the majority of my sleep clinics. And then we also see narcolepsy patients. So about 10% of my practice is narcolepsy patients. We see restless leg, parasomnias, these abnormal nighttime activities like sleepwalking, night terrors, et cetera. And then since I'm a child neurologist, I also tend to see a lot of just abnormal spells at night. Question mark, could this be epilepsy or nocturnal seizures? So a variety.
Yeah, interesting. Do you work with any other specialists or specialties closely as a sleep medicine specialist?
Certainly our ENT physicians are probably like a phone call away for most of our patients, because if they do have obstructive sleep apnea, they usually, for the young kids, require surgical intervention. We send a good chunk of our children to allergy immunology if they have a prominent component of allergic rhinitis or seasonal allergies that are contributing to large tonsils and adenoids that can be obstructing their airway. If they have complicated pulmonary conditions, if they have like restrictive lung disease, then we're working with our pediatric pulmonologists. And then we're always partnering with their primary care physicians, because oftentimes there are things that can be done, and the messaging coming from both physicians is important. So we're usually sending the information from our visits back to their medical kind of headquarters, which is their primary care physician.
Interesting. Okay. So you talked about the training path, what that looks like to become both a pediatric neurologist and a sleep medicine specialist. Mm-hmm. Talk about the journey on the other side. Where do sleep medicine specialists particularly practice? Are the majority of you in academic medicine? Are they out in the community? Is it a good mix of both?
Yeah, I think it's a pretty good mix of both. The ones I know in North Carolina, I think the majority are probably in academic centers. You just tend to gravitate towards academic centers because there are more children that have complicated airway issues and other medical comorbidities that will make it more likely for them to end up having sleep-related issues. But I know a good chunk that are also in private practice. The great thing about pediatric neurology and all the subspecialties is, you really have that choice. And I feel like almost any medical subspecialty, there's going to be a division here, and you can choose what works best for kind of you and your family and your lifestyle and your geographic region, preference, et cetera. So.
Yeah. For the super hands-on people, how procedure heavy is the specialty?
Yeah, it depends on if you want to subspecialize. So if you're going to be a general child neurologist, the majority, if you're going to have something procedural, it's going to be lumbar punctures that you might help with for patients. But even that, mostly general pediatricians can handle 99% of lumbar punctures. If you subspecialize, let's say in neuromuscular pediatric neurology, then you do a procedure known as an EMG nerve conduction study, where you're studying the firing patterns of electricity from the nerves and in the muscles from the peripheral nervous system. If you specialize in sleep medicine, you get to read polysomnographies. And so that's a procedure that we don't administer it ourselves, but we actually interpret the study. And then if you specialize in epilepsy, you'll be reading EEGs, electroencephalograms, where we look at the brainwave activity for children that we suspect are having seizures. So yeah, lots of things you can do procedural based in child neurology.
Yeah. A lot of people pick their specialty based on, am I going to have to be called into the hospital for an emergency at 2 a.m. in the morning, or am I not? How emergency heavy is your specialty?
Yeah, I think a lot of this will depend on if you're in private practice versus academia. In private practice, you're usually going to be the first call, and so you'll likely be on the phone talking. But there'll be rare situations, almost none, where you'll have to actually come into the hospital, unless it's a child that you suspect is having like a stroke, and then you have to go in and see if they require immediate intervention. In academia, thankfully, we have amazing trainees like our residents and fellows that are in the hospital that can help out with nighttime stuff. And so I've never had to go in after hours back into the hospital for any sort of emergency, because I have really smart people that I can trust that are already in the hospital that are helping out. So.
Nice. It helps have the first line defense there.
That's right. Yeah. There's a few lines of defense. We have like our peds residents, our peds interns residents, our child neurology fellows. We have ICU attendings. We have all sorts of people that are in the hospital to help.
Nice. So you have a moat between you and a phone call.
Somewhat. That's right. Yeah.
That's very smart. Very smart way of doing it. Do you feel like you have good work-life balance?
Yeah, I think I do. I think. At the end of the day, it's all about making sure you're enjoying what you're doing, no matter what you choose. And I always think of it, for me, it's work-life synergy, which is, I don't mind, on the weekends where if I have things to do and get some things done, It doesn't bother me, And then similarly, if I'm at work, yeah, sometimes I can knock out some of my home things I had to do. Maybe there's some bills I had to pay, et cetera, if I have a few minutes. And so, I encourage everybody to think of it as work-life synergy. If you're in the hospital, that's fine. If you're at home, don't feel like, I have to protect this home time. Otherwise, I'm not going to be recharged and refreshed. Get to a point where you feel comfortable just doing what you need to do from home and work throughout the day and night if necessary. And I think it leads to just a more happy and kind of fulfilling life, not to draw clear boundaries.
Yeah, you give yourself less of a hard time if you don't have those hard boundaries.
That's right.
I like the synergy. I've heard work-life integration as well.
I love that. Yeah.
Just one big pot of hours and use them as you wish.
That's right. Yeah.
So, when you look at what you're doing day in and day out, what do you love about it?
Yeah, I'm fortunate that I get to work with some wonderful colleagues. And so by default, I think if you're in child neurology, anything in pediatrics, you're going to work with people that are very friendly, that love what they do, that are team players and know how to get along. And so I get to work with some amazing colleagues. And, and again, day in and day out, when you're treating children, you almost have no choice but to be happy and upbeat and optimistic, because children bring that out in you, They are by nature upbeat, happy, optimistic, happy-go-lucky, And so, I really thrive off of that energy that kids give me, And I come into an office visit, they've drawn a picture for me, like, here you go, Dr. K. I mean, it just makes my day, it makes my week. And so I think getting that energy from patients is really wonderful. And then, the trust that they put in you, that parents put in you, to take care of their children that are having something going on with the nervous system or with their sleep issues. That trust is something that I don't take for granted, and I really kind of appreciate it, and I honor that bond that I have with these families. And so that's what keeps me happy, keeps me fulfilled, and very satisfied with what I do.
Yeah. Rosanna has a good question here. How do you navigate cases where parents disagree with your treatment plan? I think over the pandemic, we've seen a lot of potential pushback against science, against experts. And I don't know how much of that is amplified in media versus what you're seeing on the ground in the actual office.
But by the time they're in my clinic, I rarely see it.
Yeah.
I rarely see somebody that comes up to me and says, I'm not going to do what you recommended, doc. Because by default, the fact that they're there is because they want my opinion, and they respect my expertise. And so by the time they're in clinic, I've never had a situation where I'm trying to convince somebody to put a child on a treatment. Now, it's also a partnership. And so if a parent says, for sleep, for example, where the stakes are a little bit, and sleep is of course important, but the stakes aren't as high as when it comes to epilepsy treatment. And so if I give 5 recommendations and parents are like, I don't think I can do 2 of these. Well, then let's talk about it. It's a partnership where we have to figure out what's going to work and discuss the likelihood of success. And I try to be honest. I say, listen, I'm here to give you my opinion. I respect your opinion as well. And then, we discuss my rationale. And usually when you appeal to a sound rationale, people get it. People are like, yeah, that makes sense. And then we move on from there. Now, what happens at home, even though in the office we may come to an agreement, what happens at home may be different. So by the time I see them next time and we're discussing, things may not have gone as expected. But that's also life. That's just parents are at home and other issues come up and they might not have been able to implement the plan. But it's usually not because they disagree with me. It's usually because there have been other challenges that prevent them from implementing the plan.
Yeah. Interesting. Chloe asks, any advice for how to explore pediatric neurology in medical school?
I think depending on where you are, most places will have almost all large tertiary care, like medical centers, should have a pediatric neurology presence. If they don't, within the hospital, there's likely going to be something nearby, because if you're in a city that's large enough to harbor a medical school, you're likely going to have a pediatric neurologist available. So, I would reach out to them. Most pediatric neurologists would love to recruit more folks into the field, just because we don't have enough and we need to continue to expand. And so shoot them an email and say, hey, listen, I'm in medical school here. I would love to spend a day or 2 with you in clinic, or around with you on the floor if they're actually covering inpatient, and get a sense of what it's like. I will tell you, though, that during your core rotations, when you do pediatrics and hopefully have a chance to do pediatric neurology, the inpatient side of things is much different than the outpatient side of things. And sometimes the inpatient side of things can be a little bit disheartening, and there can be some sad situations. And I encourage everybody to make sure they're looking at the whole picture, because there are a lot of things that happen in the outpatient world that help balance out some of the more challenging cases you see at inpatient. So don't make the decision just based on what you're seeing inpatient, because for most, that's actually a minority of our practice. I cover inpatient for maybe 2 to 3 months out of the year. Most of my time is spent in the clinic, and that's a different scene.
Yeah. And that's a big part of why I started having these conversations with physicians and their specialties, and trying to be very intentional about, I want to talk to an academic physician in whatever specialty. I want to talk to a community physician in whatever specialty, and compare and contrast the two, because unfortunately, as we go through medical training, it's typically urban academic medicine, and that's not the majority of medicine that's practiced in the country. And so to really give a good idea of what's out there and what your future may look like.
Absolutely. And that's also very important when you're going through just medical school, because people are going to, the academicians that are around you are going to be like, oh yeah, you should do academics, et cetera. And I say, no. When you're even after residency, when in residency, you're going to be in an academic medical center. So, it is up to you to make sure that you explore all the opportunities available to you. Don't get caught up in the academia is the only way to go, because that's what you're going to be faced with, during your training. Yeah. Make sure you're exploring private practice and rural practices, et cetera, because they are vitally important.
Yeah. I always wondered why there's such a love fest, for a lack of a better word, of academicians, if that's the right word, pushing academics, right? Why? Like, I know my wife, when she finished her neurology residency at Mass General, like, she was considered a failure because she didn't go into an academic fellowship. She went into a community-based fellowship, but they didn't like that it wasn't academic, Harvard-based. Like, they considered that not good. And I'm like, why? Based on what? It's so weird.
Yeah, I mean, and honestly, like you mentioned, the bulk of like the medicine is being handled outside of the academic world, and so. And then again, everything has its place. And so I'll tell you, when in Greece, you're going to, so when you're in academia, people are going to, of course, they're already in that culture. They're like, oh yeah, you have to produce research and you have to advance the field. And this is like, the honorable way of doing things. But the flip side is, if you go out to a private practice group, they'll be like, gosh, I'm seeing 20 patients a day, whereas my academic colleague might be seeing 10 patients a day. I'm taking care of a lot more problems and and helping a lot more people in a different way, in a different way. So neither of them are wrong. It's all based on kind of where your interests lie and what's going to make you a happy, fulfilled individual.
Yeah. What does a typical day look like for you, or a typical week if you don't have a typical day?
Yeah, well, over time, I've gotten into the educational side of things. So the past 5 years, I was the program director for the child neurology residency program here at Duke. And so a lot of my time was spent making sure that the program was running well. And so in academics, we have protected time to make sure that we're fulfilling the education and academic mission. And so I spent a lot of my time doing that. When I started off at Duke, I had three days of clinic, so 6 half days of clinic. And then the rest of the time was spent reading sleep studies, dabbling in research, and dealing with patient-related phone calls and administrative stuff. And so it's much different than, what life as a resident and as a medical student, where it's, every single day you're grinding it out. Once you hit the faculty level and an academic practice, usually there's some protected time to do things like research and, other educational focused things.
Yeah. What for you was a driving factor into getting more into the medical education side of things?
Yeah, I've always been interested in, med ed, ever since we've known each other. It's always been nice to kind of give information to help folks along, because the journey can be rough with lots of ups and downs. And so being able to contribute to that, being able to kind of help support residents during kind of a critical time in their careers was something that I enjoyed. I still love, mentoring the medical students that come through Duke as well, when they're interested in child neurology. And so, for all those reasons, I still love, I'm in charge of recruitment still. So I'm the associate program director, even though I turned the role over. I enjoy the interview process, meeting all of these really just amazing medical students, seeing what they've done and why they've been interested in, gotten interested in my field. So we keep it going. Yeah.
Yeah, that's good.
We got to replace ourselves, Ryan. Like we need smart people to come in and let us retire someday, and so
retire. What's that?
Mission alive, Yeah.
Never retire. You gotta be in the newspaper as like 105-year-old doctor still rounding.
That's right. Yeah. Well, some people do that, and that's, more
Yeah.
power to them. It's
Yep.
a lifelong endeavor. So.
Vijay asks, how does your communication vary between parents and children? Anything you do specifically to help ease children who may be anxious?
Yeah, Vijay, a lot of the neuro exam is actually, depending on the age, is play based. In order for me to to figure out what the strength is for an 18-month-old and to figure out how the reflexes are working, I cannot just go up to them and start banging on their legs and start pulling at arms and limbs. They're going to freak out, and they're going to, I'm not going to get very far. So much of my initial communication, I walk into a room, although I usually acknowledge a child if they're young, is focused on the parent with a lot of peripheral kind of like play and being lighthearted with the child. And that's where I get the best neuro exam. The child is relaxed and, receptive. And so, I'll have them, we'll usually have toys in our bag, right? And so we'll put a toy in my hand and see if the child is reaching out for the toy, see how hard they can grab it and try to pull it away from me. There are all these little tricks you can do to get confidence from the child and also get a good neuro exam. With parents, a lot of it is, we try our best to make sure we're avoiding medical jargon. We spend all these years learning all the medical jargon in order to not be able to use it. That's kind of the goal, to be able to explain things in a way that makes them understand and cuts through all of the jargon. And so that's my goal, is when they leave the room, they should have a firm understanding of what I know. And almost as importantly, they should also understand what I don't know, because there's a lot of gray territory in medicine, and rarely do we have the exact right answer for the exact right problem. And so we you want to leave the family with an understanding of what falls in each category. They shouldn't leave confused. They should have a firm understanding of what's going on in my brain and my rationale. That's the goal.
Yeah. Wyatt asks a similar question about handling pediatric patients and discussing what's wrong with them. Now, obviously, kids probably got to be a little bit older for you to be communicating diagnoses to the kid versus the parent. But how do you handle those situations?
Yeah, usually when the child is older, it's readily apparent to them if there is a neurologic issue for a child that's otherwise healthy, like epilepsy, for example. They're very much part of the conversation from the beginning. There's not much that we're withholding, et cetera. For younger children, we always defer to the parents regarding how much they want to discuss in front of the child. Even when it comes to discussing the symptoms the child may have been experiencing, sometimes parents are like, can we have this conversation outside the room? So we defer to what the parents would prefer and make sure we're creating that balance between what's necessary to tell a child and based on their age, what's age appropriate.
Yeah, interesting. Alexandra asks, how do we find people in medical school or in the pre-med years that support the point of view to explore private practice or community-based opportunities?
I would say find the private practice folks and the community-based folks. This is something I set up a rotation during medical school. Actually, it was during my early part of my residency, where I'm like, I want to go rotate with that private practice pediatric neurology group, and they were okay with that. So I think people understand that you have a choice and you need to explore. And most people in private practice, thankfully, don't have as much kind of red tape to cut through to get permission for you to be there, learning about patients and seeing patients. And so it might be a lot easier than you think.
Yeah. Rosanna asks, did your fellowship training help with trying to understand mental health and sleep issues? Correlation there.
Totally. Yeah. If you have a problem with sleep, it worsens just about every medical, psychiatric, psychosocial condition that you can experience. That's also the wonderful thing about sleep. When you fix it, suddenly everything improves. And mood disorders certainly tie into sleep dysfunction. And then if you have sleep dysfunction, it can also worsen mood disorders. And so it can be a bit of a snowball effect. I'm very much in tune to making sure I'm screening for mental health related comorbidities. And if those are present, I have wonderful colleagues that I make sure are involved with the treatment process. My child psychiatrists and psychologists, therapists, we have a great team and we work together on a variety of children that need support from both angles.
Yeah. For the future primary care physician, for the future pediatrician who unfortunately doesn't go into pediatric neurology, they stay a general pediatrician. What do you want them to take away from this talk so that they can help their patients see the sleep specialist or the pediatric neurologist sooner to help diagnose things?
Yeah, I would say just know what your resources are in your area, because there's usually somebody for just about everything. So once it gets to the level where you're like, gosh, and this is kind of out of my ballpark, reach out to your subspecialists. I'll tell you, from a common referral standpoint, migraine headaches, anything that looks like epilepsy, developmental issues or concerns about weakness, muscular dystrophy type stuff, abnormal movement like tics and movement disorders, all that stuff we oftentimes see. And then unfortunately, from a sleep standpoint, I'll tell you that the training, both in medical school and residency, is poor. It's incredibly limited. I didn't learn, I learned 99% of what I do now during my 1-year sleep fellowship. I didn't learn nearly enough during residency. And that's why actually part of the reason I'm out there is sharing, sleep related advice through my Twitter channel and my Instagram feed, is to hopefully educate the community and other physicians about the importance of sleep and things that they can do to help their patients.
Yeah. Including wonderful sleep puns like don't give up on your dreams, keep sleeping.
That's right. Absolutely. One of my graduating residents gave me that mug. They know how much I preach sleep,
Yeah.
Like sleep is just something that I just have a passion about. So yeah.
Yeah. I love sleeping with my Apple Watch and gathering lots of data. So I sleep with my Apple Watch on, and I use an app to track my sleep. And I don't know if it's a placebo effect, but when I look at the data, I'm like, yep, that's how I feel.
Yeah.
And when it's good or when it's bad, I'm like, oh yeah, that was a bad night.
Yeah. Well,
So do you find that the invention of all this technology around sleep is helping your patients maybe come in a little bit sooner, going, we thought something was up, we put a watch on them or a ring on them, and it's showing all this wacky stuff?
Yes, I think it is raising awareness. That's probably where the benefit ends.
Yeah.
Of all the trackers,
Yeah.
And I hate to be kind of like a Debbie Downer on trackers, but the technology is just not that great.
Yeah.
They love to try to break it down into REM sleep and deep sleep and light sleep, and I'm like, unless your tracker has like an EEG port that goes directly into there, and you have a human that's interpreting it, it doesn't know anything about deep versus light sleep. Although, all that stuff is black box proprietary algorithms that no one's going to share with us. So who knows how they come up with it? But it's, it's hard to do. It's hard to do. But now it's actually really good at detecting, sleep versus wake. And so when it gives you a sense of you've been asleep for this many hours, that's pretty reliable. And the average adult, we're talking 7 to 9 hours is typical. 7 to 9 hours. The average adult needs a little bit more than 8 hours of sleep to feel fully refreshed. And so if it's giving you that feedback to say, you only slept 7 hours the last few nights, that's advice I think you can take to heart and say, maybe I do need to make a change.
Yeah. Okay. Chloe asks a good question. Do you see patients for many years throughout their childhood? So is your specialty one where you have good longitudinal follow through with the patients?
Yeah, I'll see a newborn all the way through, early 20s. My oldest patient is probably in the early to mid 20s. There'll be some patients that I just hang on to because I don't want them to leave. I'm like, oh, I've treated you for 10 years. I'm just going to have you stick around in my clinic. So, particularly my patients that have narcolepsy, I tend to hang on to them a little bit longer. Everybody has a different approach to this, and depending on what subspecialty you're in, there'll be some that hang on to them for life. Like pediatric cardiologists, if they have a complex congenital heart disease, sometimes they continue to follow them because adult cardiologists don't know how to deal with that particular congenital heart disease. So, so it really depends on your
I would hate to be that 6-year-old patient. Like, great that you have a congenital heart disease living to 60, but you're the old dude in the room filled with pediatric patients.
It just kind of goes to show how good the medicine has become over time. We have cohorts of patients that have never walked the planet. Like, for example, Pompe disease is this devastating metabolic disorder, infantile Pompe disease. But now, because enzyme replacement therapy was invented, we have actually at Duke, we have the world's expert at Duke. She has a cohort of patients that are now in their teens. The world has never seen teenagers with infantile Pompe. That's how amazing the medicine is right now. We've never seen teenagers with infantile Pompe. So we're figuring out a whole new kind of phenotype to this disease. So it's pretty amazing.
Yeah, well, let's transition to that. I was gonna potentially bring it up, but you just mentioned that. medications are huge. We've seen huge strides in medications for a pediatric neurology disorder, SMA, where Zolgensma is, I think, still holds the crown for most expensive drug on the market, a $2.1 million kind of retail price. What are your thoughts when you're like, yeah, hey, patient, we have a life-changing drug for you. I hope your insurance covers it.
Yeah. I will tell you that for children, I don't think any insurance company wants to be the one that's denied a child a life-saving intervention. And so, although it does take some finagling, I've never seen a situation where insurance is like, we're not going to cover this if it's the right intervention for the right disease. Now, there are some people that are like, I want to use this off-label, and the research hasn't really shown that, but I want to use it as a research purpose. Well, then usually you're looking for a research trial to support that. We can't. So we have to be fair to all the parties. We can't expect insurance to cover things willy-nilly, because then people are going to kind of write their own prescriptions. But it has to be based on science and the right indication for the right disorder. But you're right. Some things are becoming astronomical. And by nature, new technology tends to be expensive, and so some of that is expected. But when you start developing these precision tools like gene therapy that are one-time administrations, and now your disease is cured, there's going to be a lot of ethical considerations regarding how much you can charge for that. Because for the pharmaceutical companies are like, well, we developed this and we put so much research into it, and I'm going to give it to you one time and you're going to be done. How am I going to make this a viable business thing from a business standpoint? That's the way they're thinking about things. Whereas the doctors were like, just give them the medicine, just give them the drug, it's going to be better. How can you withhold this? And so a lot of ethical things come up. It's a challenge.
Yeah. I asked you earlier, what do you like the most about what you do? What do you like the least about your specialty?
Delivering some really sad news, I think, it can be challenging. We, unfortunately, as child neurologists in our hospital, we also do the brain death evaluations. And so declaring a child brain dead is the worst thing that I have to do. But thankfully, it's rare that I have to do that. But there's bad news in any subspecialty. In any specialty, there's going to be delivering bad news. That's something that you have to develop, a way to do and a way to cope with. So
VJ asks, did you find an improvement in your own sleep during your training?
100%. Man, let me tell you, if I could go back and do this all again, I remember ever since like high school, all the way through undergrad, I'd crack open a book and I'd fall asleep in 5 minutes, because I was just chronically sleep deprived. And I convinced myself, I'm just bored, and this is just how I've gotten used to learning. I have to do it in these intervals between little quick cat naps. And all the while, I just was never getting enough sleep. I told myself the entire junior year of college, I was like, I only need 6 hours of sleep. Complete baloney. I was falling asleep in every class, and I made it 10 times harder on myself. If you are actually wide awake and your brain is ready to learn, if you sit in class, you can actually do half of your studying in class, because you're actually absorbing the information, as opposed to just using class to sit there to be in attendance and then everything later. There's so much more you can do if you just give your brain the opportunity to do it. And people are like, oh, well, how am I supposed to sleep? I got so much work to do, and I can't possibly get 8 hours of sleep a night. And I'm like, well, if you're 200% more efficient, you get your work done in half the time. Yes, actually, you can sleep 8 hours at night, and you'll be just fine, because you'll actually be a better student. You'll be getting more efficient work done, and you'll be happier and healthier for it. You don't have to sacrifice your health to become a physician, and when you're a physician, you also don't have to sacrifice your health. So,
well, Sujay, you'll be proud. I slept almost 9.5 hours last night.
Good for you. All right. Yeah. You're probably making up for sleep that you lost, I bet.
Well, yeah. The night before wasn't great, but I've been trying to get 8 or 9 hours a night lately, and it works well. I like it. Yeah. I like it. I'm watching a lot less TV, which is kind of sucky, but hey, whatever.
It's a free energy drink, man. I mean, it's people are slamming all these highly caffeinated beverages, looking for a secret to for these body hacks to be able to stay awake, and sleep is actually the hack.
Sleep is the hack. Sleep's the hack. Yeah. I'm not a coffee guy. I don't do caffeine or anything. So I'm just high on life. High
You got
on
so what do you
medical
think?
education. So,
Yes,
do you have a case for us today or no? Did
I'll
did
be
you prepare a
happy
case?
to share a case. You want me to share a case?
Yeah, it'd be awesome. Do you want to bring
Totally,
someone on?
yeah.
We can ask them some questions.
Do I have somebody to bring on
No,
to ask questions to?
should we bring someone on and we can ask them questions about the case?
Oh, hey, you run this however you want. I'm happy to. I'm flexible. Whatever you like to do. Yeah.
All right. If you want
I'm trying
to,
to think. Should I make it a really hard case?
yeah, of course.
Okay, got it.
If you want to raise your hand to come on and be pimped a little bit here, as we call it in the medical education world, raise your hand and we'll bring you on. Before then, we'll just go ahead and get started. I don't know if anyone's going to raise their hand. Having some breakdown. Is it me or is it Sujay? You guys hear me okay?
I think I can hear you now. Sorry, I think it's me. Can you hear me okay?
You're coming back.
I think it's okay. Sorry.
Maybe. Your video's frozen though.
That's unfortunate. Let me switch. Let me try switching to different Wi-Fi here. Hang with me.
Yep.
Can you hear me?
I can hear you. Maybe.
Okay. All right.
Maybe not.
Hopefully this works.
Yeah. Well, we'll see. Hello, VJ.
Hello.
Thanks for volunteering.
Yeah, no problem.
All right, let's rock and roll.
All right, cool. So VJ, you're a child neurologist, and a parent brings a 6-year-old into clinic, and they say, I'm worried that my child is having problems with attention. All right. And the history is the teacher reports that the child has multiple bouts every single day of just kind of daydreaming in school. And the child is not paying attention. It takes about 10 seconds or so. The child's eyes just kind of tend to drift off. And then by the time the teacher calls his name, he's back to it and is like, what's wrong? And she's like, hey, you're daydreaming again. And the parent finally brought the kid in because they've been noticing it at home as well. And when the child is, even sometimes during activity, you notice the child kind of goes into dream world. While the child is there in the clinic with you, the child looks otherwise healthy and the exam is completely normal. And so the first question here is, what are the different things this could be, for a 6-year-old coming in with challenges with attention?
Oh, okay. I don't know. I guess I feel like the typical thing to think of with any type of attention deficit would be like ADD, ADHD. Since you're working in the field of sleep, I would maybe see if there's anything concerning their sleep that might be affecting their attention, because we just talked about how you would also kind of doze off and then come back into it every once in a while. So that would be a potential cause of it if they're not getting adequate sleep. If maybe if there's something going on while they're sleeping, there's some people who I've heard get seizures while they're asleep and maybe they're not aware of it, they're not conscious of it. That's where my mind goes, but yeah.
Great differential. Now, let's say that while you're examining the child, you ask them to do a maneuver that we sometimes use in child. We ask them to hyperventilate. We ask them to breathe, take deep breaths in and out for about 2 minutes. We usually do this with a pinwheel that they blow on to turn the pinwheel. And while the child is doing it, the child suddenly stops, eyes float upward, and the child picks at their shirt for about 10 seconds and then snaps out of it and is like, what? And then starts blowing on the pinwheel again. Does that change your mind regarding which direction you're going to go here?
It broke up a little bit, but so I apologize, but from what I did hear, maybe a little bit. I at that point, I'm not sure if I would think too much like ADD, ADHD. So the direction of my mind might go elsewhere. I think from what I heard, you mentioned that their eyes go up, you said, and then they're pulling on their shirt and then they start blowing on the pinwheel again. Yeah, it definitely changes the direction of my mind, but I don't know where to be honest.
Okay. Yeah. All right. And
All
then,
right.
so let's say since you're in the child neurology clinic, you're worried about a specific type of neurologic disorder, which tends to come on around this age, young children that are otherwise healthy, which you can diagnose based on an EEG finding,
Okay.
based on abnormal brainwave activity.
Yeah, I mean,
If they
I
have,
think. Oh, sorry, I didn't mean to cut you off. Go ahead.
no, go ahead. Yeah.
Oh, I think someone put in the comments, and I agree. I guess my head's going towards like seizure-y type of activities. I had a seizure, and they did some similar, like, tests on me. So I guess like that's where my mind is going.
Yeah, that's right. This is a specific type of epilepsy known as childhood absence epilepsy. Absence seizures can be very short. They usually occur tens of times in a day. And there's usually what we call no post-ictal manifestation, which means after the seizure is done, there's usually not too much confusion or fatigue. They just snap right out of it. They might be confused for just like a second, and then they're right back into it. And the finding on the EEG, if you're looking at their brainwave activity, even when they're not having a seizure, oftentimes you're going to see abnormal discharges from the brain, something that we call generalized spike wave activity. And while they're having a seizure, you'll see that spike wave activity kind of continuously for the entire duration of the seizure. So this is childhood absence epilepsy. It's typically treated with a very effective medicine known as ethosuximide, which is a very common board question for all you budding pediatric neurologists or pediatricians out there. Remember that absence epilepsy treatment is ethosuximide, and you want to treat it because oftentimes mistaken for ADHD and attention issues, and it's really not the child's fault. They're having seizures and they can't control it.
Yeah, but I actually worked as a behavioral therapist, and we had a child. I didn't know the term of the condition, but they did mention, or like our superiors mentioned that he would potentially get seizures from times, and it might look like he's nodding off, but it could potentially be a seizure. So to notify them if that's the case. So I didn't know that was what the condition name is, but now I do. So thank you.
There you go. You're welcome.
There you go. Good job. Good job. All right. Well, we'll wrap up a little bit early, having some internet glitchy stuff as we do. It's the East Coast, everyone getting off of work right around now, upping their Netflix usage to start binging for the evening. Dr. Sujay Kansagra on Twitter, Med School Advice. Go follow Sujay and
now Instagram. That's Sleep Doc. It's all sleep related account on Instagram. That's Sleep Doc.
There you go. But the big question is, Sujay, are you on TikTok yet?
I am. That's Sleep Doc, even on TikTok.
All right.
Started.
There you go.
Yeah.
Good. TikTok is phenomenal. Any final words of wisdom here for the student watching, potentially now a budding pediatric neurologist and sleep specialist in their future?
Best of luck on the journey. It's a long road. I always tell people enjoy the journey. That in medical school and medical education, it never ends. The work continues. There's no real end to it. So you got to enjoy the journey along the way. So, and part of that is sleeping well. So sleep well and enjoy the journey.
Sleep well, everyone. Sujay, thanks for joining. It's great catching up. Everyone else, I hope you have a wonderful day, and we'll see you soon. Bye-bye.